Monthly Ontario Network for Indigenous Health Research's webinar. My name is Suzanne Stewart, and I'm the director of the Wakabin S. Bryce Institute for Indigenous Health Research here at the Dahlana School of Public Health at the University of Toronto. I'm also the nominated PI for the Ontario NEIHR. And we're here today to welcome our elder in residence, knowledge keeper Clayton Shirt, and our monthly featured amazing speaker and Ontario NEIHR co-investigator, Dr. Jeffrey Ansloos. And we're going to start off today by inviting our knowledge keeper to open us up with a spiritual prayer and to invite spirit into our virtual circle. Clay?
Oh, Miigwech, thank you. I'll get right into the prayer, and then I'll just say Miigwech and take a moment or two. I know this is very difficult for some of us in the virtual world, and this is a virtual circle. And so just picture yourself in a circle, and and just offer your prayers. And there's many views who come to the circles. I'll just point out a few. There's a spiritual view, there's a religious view, there's agnostic view, there is an atheist view. There are many views, but we all enter the circle with different views, but we can all agree on this one thing, that we are the people. We come together as the people. Our bone, our flesh, our blood is the liquids and minerals of the earth, the human. The being comes from our relationship to the sun, to the sky, to the universe. We are the human beings. We humble ourselves. And so I have the privilege and honor, and it is an honor to say the opening prayer. I'll say it in this language. This is the only language I speak. And so I'll say it in this language, and I just offer my prayers, my thoughts, my heart to the earth. I offer to our mother. We call her our mother. I call her my mother. I offer my prayers in gratitude. I humble myself. I say Miigwech to our mother, the earth, for providing everything for us, the people, and our relatives. We give thanks for this. For the medicines, those 4 medicines, I offer my sema in gratitude. And I thank her for my heart. We come together as the people. We humble ourselves. We say Miigwech to her for everything. I offer my prayers to Father Sky. Again, I partition, I stand here as a man, just a man. I offer my prayers, my sema to Father Sky. Again, I partition, I ask the spirits of my ancestors to be here with us in a good way, in a kind way. Your ancestors, my ancestors, to help us, to guide us physically, mentally, spiritually, emotionally, in all these ways, to help us in these very difficult, challenging times. We humble ourselves. We say Miigwech to you, to our ancestors, to Father Sky. I give thanks to the sun again for a new day, a new beginning, for bringing the warmth, for bringing light, for making the medicines grow for us, the people. I say thank you to Grandfather Sun for giving the appearance of rising in that sacred doorway, that eastern doorway. I say thank you for this day and this moment, for this is all I have is this moment right now. I humble myself with this moment. I say thank you for this. And if I have done anything in the past, I have this day, this moment to make it right. And I thank you for this, Grandfather Sun. I give my thoughts to, we give our thoughts to grandmother, grandmother of all grandmothers. We humble ourselves again. We send our prayers, our thoughts. I pray to you, I pray for you. I give thanks for everything you do for us, Nukamis. Grandmother of all grandmothers, Grandma Moon. You are so beautiful in the night. I thank you for this. I thank you for bringing light in the night. I thank you for everything. But I especially thank you for this one thing that I forget so often, that you put into order for us as my children sleep, as my granddaughter sleeps, as we sleep, the people. You put the waters, the rivers, the lakes, the oceans into order for us, for we acknowledge this. I acknowledge this, for water is life. And may this always be in my mind and my heart that I forget so often. But I thank you again, Nukamis, for so many things you do for us. I love you. I say Miigwech to you, Nukamis. You are so beautiful in the night. So our minds, our hearts are one with this. I say Miigwech. I offer my prayers for all of us. Again, I humble myself. I say Miigwech to you, Creator. Again, the great mystery, for there is nothing beyond you, Creator. I thank you for this beautiful gift called life. I ask for your blessings today for all of us who come together in this virtual circle. It is very challenging, very difficult, but I offer my prayers to you for all of us to protect us, to watch over us, to give us strength in these difficult times. I say thank you, Creator, again, Creator, for there is nothing beyond you. I thank you for this beautiful gift you have given us called life. All my relations. Miigwech, miigwech, miigwech. It's all you, Jeffrey.
So I'd like to just introduce you briefly, Jeffrey, if that's okay, and to really welcome you to our monthly Ontario NEIHR Speaker Series and say what a great honor and pleasure it is to learn about the work that you're doing right now in Indigenous mental health promotion during the COVID-19 pandemic, and to say how thrilled we are to be working together between Waakabeness and your lab at OISE. And, you know, I first met Dr. Ansloos, I would imagine that was 8 or 10 years ago through the Canadian Psychology Association. And it's been a real thrill to watch Jeffrey develop to be one of our leading scholars in Indigenous mental health in Canada. So, so thank you for being here. And I'm not going to keep talking, but I'm going to let you start now. So, miigwech. Oh, and just one quick bit of housekeeping to our attendees. There will be about 10 or 15 minutes at the end for questions. So if you have questions for Dr. Ansloos, please type them into the Q&A box. And this session is also being recorded and archived on the Ontario NEIHR website, as well as on the Waakabeness Bryce Institute for Indigenous Health Research YouTube channel. So if you aren't able to stay the whole time or other people want to see it, you can let them know where to find it. And we can post that link in the chat. So miigwech.
Good afternoon, everybody. Thank you so much for being here today. I'm going to forewarn everyone that I have a 9-month-old puppy who is quite vocal, and it would not be the first time she has joined in a webinar vocally howling or yawning or these sorts of things, but she likes to sit right at my feet, which is where she is at the moment. So if you hear strange sounds, it's my puppy, whose name is Blueberry, and that has nothing else to do with the presentation I'm about to give today, but I thought I'd give you that little preamble. I'm really delighted to share some of the learning that we've been doing in the context of my research lab over the last year. What I'm going to present to you today is really a work in progress. Initially, some of my colleagues and I started working on this paper about 6 months ago, and it's kind of evolved into a really interesting project, which you're going to get components of today. Really, it's lessons of what we've learned about Indigenous public health communications and mental health promotion during the COVID-19 pandemic. It's been a trying year for many, and I think in the midst of it all, there's just what I love about this opportunity to meet with you all today is to take a pause and see what we've learned about how our responses over the course of the last year have evolved in relationship to this pandemic and serving the needs of Indigenous communities. I want to start off by offering thanks and gratitude to people that aren't here presenting today with me, but those include members of the Critical Health and Social Action Labs at the University of Toronto. In particular, I want to thank our Indigenous outreach librarian, Desmond Wong, who is a co-author in the Indigenous COVID-19 resource guide, from which I'm going to be speaking a little bit about today. But I also want to offer thanks to Kara Samuel, Deanna Zanting, Rachel Thornburg, and Shannon Rowe, who've all supported some of the research that's presented here today in very important ways, including reviewing literature, supporting ethics proposals and data collection and analysis, all amid a global pandemic. I also want to thank and acknowledge the funding support of the Social Sciences and Humanities Research Council of Canada, which fund my students' work and this work as well. And maybe before I continue, I'll maybe just say a little bit more about who I am. I come originally from Winnipeg is where I grew up. My family comes from all over the world, but on my mom's side from Fisher River Cree Nation, of which I'm a citizen. On my dad's side, the UK. And, presently I work here in Toronto and just want to offer gratitude, but also mindful in what we're going to speak about today of the impacts of colonialism in spaces like Toronto and the way that that's impacted Indigenous communities. But to acknowledge that I work and I do this research together with students in the territory of Anishinaabe and Haudenosaunee here in Toronto. And I just want to premise what I'm going to say with that, not as a sort of nod because we're supposed to, but because really these relationships with Indigenous communities form the basis of our accountability for the work that we do in the university and in public health institutions, which are often complicit in violence against Indigenous people. And so I want to sort of begin that way and position this work with that level of accountability today. It's sort of a pathway for what I want to present today. And I don't know that we'll have time to go through all of it, but I want to sort of start off by talking a little bit about some of the context of talking about Indigenous health and mental health in the midst of a global pandemic like COVID-19. And I want to raise some of the particular health communications challenges that were faced in this pandemic, both at a conceptual level and also at the level of practicing public health in Indigenous communities. I want to then pivot and talk a little bit about this interesting thing that happened early in the pandemic, which was the development of the Indigenous COVID-19 Resource Guide project, which is housed by the University of Toronto Library. It really didn't start out as a research project, but it has kind of evolved into one. And I'm going to talk a little bit about some of the emerging key lessons for Indigenous public health communications and mental health promotion that we are seeing in this really wonderful archive of materials. I guess to start off, I want to sort of talk through some of the ways in which COVID-19 has been positioned in relationship to Indigenous communities. In particular, I want to start off by talking about the perception of an actual threat of population health risk to Indigenous peoples during the pandemic. Early in the pandemic, Dr. Tam, Canada's Chief Public Health Officer, said that Indigenous peoples are among the most vulnerable to COVID-19 due to distances, access to necessary resource, and underlying health conditions. But over the course of the pandemic, Indigenous communities in Canada have actually had lower rates of COVID-19 and a lower fatality rate than non-Indigenous communities. Indigenous, more specifically First Nations peoples living on reserve have had a COVID case rate 4 times lower than the general Canadian population, with 3 times fewer fatalities and almost a third higher recovery rate. So this sort of initial perception of risk, is it accurate or inaccurate, is an interesting question that we're going to look at a little bit further. But also, I think what this presentation is hopefully going to shine a light on is the wisdom of Indigenous communities in responding to this particular pandemic and what we can learn from the strengths-based responses of Indigenous peoples. So one of the ways that we look at this question of risk is by, panning in a little bit closer towards what are those social dimensions of these perceived and actual risks of Indigenous communities in the midst of COVID-19. What we know for certain is that rural and northern communities have experienced challenges for a long time now, such as stable unhousing or overcrowded housing, pervasive economic oppression, sometimes called poverty, limited access to affordable and nutritious foods, sometimes called food insecurity, and then of course, unclean water. Many communities also face limited or disadvantaged clinical resources, equipment, and healthcare personnel. So this is sort of speaking to inequitable access to public health services. An estimated 56%, so more than half of rural Indigenous people, accounting for most First Nations in Canada, lack critical healthcare access and infrastructure. So these inequities combined with what we widely know today about racism in the public healthcare system really have put Indigenous communities at a higher risk for adverse health outcomes. None of that is particularly surprising or unique to COVID-19, but was a context for people thinking about the risk that COVID-19 posed to Indigenous peoples. In addition to this, Indigenous peoples have had lower life expectancies in Canada for some time and experienced disproportionate rates of chronic health problems. Some of the work that I do has more specifically looked at these inequities in the area of mental health and in suicide. And what we can certainly say is that in Canada, Indigenous people experience higher rates of mental health challenges, often described in terms of psychological distress, and that suicidal ideation and indeed completed suicide rates are higher among Indigenous people than the general population, and in particular among young people, older adults, and communities that have more historical systemic disadvantage in the areas of social determinants of health. So access to mental health services and health services is scarce in Indigenous communities, and resources that are often available for the public at large in very appropriate ways are often not culturally appropriate, not designed for Indigenous communities, and frequently do not acknowledge structural drivers of inequality like the history of colonization in the midst of Indigenous mental health and health challenges. So again, this sense of the risk that COVID-19 posed to Indigenous communities is really not imagined. The takeaway here is that the pre-existing public health challenges in Indigenous communities, and certainly the perception of risk was well-founded in that they would be these conditions might be exacerbated by the COVID-19 pandemic, contributing to gaps in service delivery, communication, elevated mental health risk, misinformation. And given that the public health challenge that COVID-19 presented, it was widely assumed that Indigenous communities really would be severely impacted in terms of fatalities. This is, important to kind of grapple with, because this context is really the space in which our, push to develop relevant health communications resources was situated. And I guess one of the key issues that became very apparent about a year ago when the pandemic, just over a year ago when the pandemic really began to spread within Canada, there really was not very much thought given to contextualize public health theory that would serve the interests of Indigenous communities. And it's very true that largely within public health research, communications theory has not been particularly developed for Indigenous communities. And I don't have time today, but I could go through all of the public health communications theories models that are out there, and there's not a single one that's been developed for Indigenous people. At best, what you'll see represented in this literature is that structural inequalities are often considered in terms of access to communication. And so, this is a real gap. The goals of public health communication are often largely centered around supporting behavioral change and adaptation towards quote unquote healthy behaviors. And I put that in quotes because of course, healthy behaviors are always contextual and relative. Although in public health, they're not always treated that way. In the context of this particular pandemic that we are facing, the key goals were often about helping people to, especially in March of last year, late February and into March of last year, really helping people to immediately begin social distancing, which later became reframed as physical distancing, to adopt various sanitation protocols, including hand washing, frequent hand washing, not touching one's face, mask wearing eventually, and then more recently accessing and taking vaccinations. So we found this to be, immediately very challenging in the context of Indigenous communities. Of course, there's some behavioral examples that have come through the literature already that I want to highlight. One being the guidelines for preventing the spread of COVID-19 outlined by the Canadian government really highlighted physical distancing, personal protective equipment, and frequent hand washing as best practices. However, there's a real lack of representation in rural and northern and remote clinics and discussions around best practices and shared policies. And as a result, many of these initial measures failed to account for the circumstances of rural and remote living. Also, recommendations like hand washing requires access to clean water and basic infrastructure facilities. And this is not practical for many communities with long-term waterboarding advisories currently in effect in Canada, or bathing advisories change in these contexts. Many households experience unstable and overcrowded housing conditions, making physical distancing and isolation very difficult, especially in contexts where multiple families are living in the same household. And so the issue of physical distancing was very severe in intergenerational homes, where transmission to elders and higher risk individuals was much more likely. There's also the mental health factors. In assessing the mental health impacts of COVID, people with pre-existing mental health conditions were more likely to deteriorate in their mental health and endorse symptoms around depression, anxiety, sadness amid this pandemic. And Indigenous people, who are more likely to report these challenges, were also, in the midst of this pandemic, more likely to report increases in areas that are relevant to mental health distress. So of course, things like physical and social distancing made these worse in communities that were already disadvantaged in not having access to many of the sorts of services and infrastructure in cities, but also who were made even more isolated by the current pandemic orders, or public health orders rather. There is also, probably most importantly, and what alerted us early in the pandemic, was the challenges of misinformation. I don't know how many of you here, the 60 some plus of you that are here today, remember early in the pandemic, but there were many reports of certain traditional medicines being sufficient for the healing of COVID-19. And of course, we could have a much broader conversation about what we mean by healing and in what context those medicines were appropriate in use. There was misinformation around transmission. Could it be transmitted in a sweat, for example? What we have learned from the research in the last year is that there actually were, in fact, examples of misinformation, not only at the level of conversations between people, but also within media. The Yellowhead Institute here in Toronto, a community-based First Nations policy think tank, reported that more than 465 Indigenous COVID cases and 7 deaths among 42 communities in Canada, while Indigenous Services Canada at the same time reported 183 on-reserve cases in 5 provinces with 2 deaths. This information at the same time was in conflict and indicates that some of the data discrepancy related to Indigenous specific health was inconsistent in the media and likely had an impact on people's perception of the severity of this pandemic. Communication gaps are not uncommon in public health communication for those groups that are often considered high risk. And these groups often are feeling excluded or are misinformed if targeted messages are not culturally specific. So there's a broader sense in which there's a need for cultural specificity in public health communications, but early in the pandemic, we have plenty of that today, but early in the pandemic, within the first month, there was actually very scarce information available. So this is what led to the development in March of 2020, the COVID-19 Resource Guide at the University of Toronto. This literally was a product of a very brief conversation that I had with my colleague Desmond Wong, our Indigenous outreach librarian, about the need to provide access through the Indigenous education networks, listserv, and to its many hundreds of members, a source of credible, collated information that could be of use for gathering relevant public health information specific to Indigenous communities. I won't go into the full method for what we selected to include in that today, but I will say that at the beginning of the pandemic, there was very little, and what we kind of began to include over the course of the pandemic really increased. But I guess the gathering materials was really premised on the need that we needed to find culturally specific and culturally appropriate materials in response to a wave of information and constantly shifting information at the beginning of the pandemic. And I guess I should clarify, at the beginning of Canada's experience of the pandemic, because of course the pandemic began before it arrived here. It was determined that the guide would gather culturally specific content in a centralized location that addressed the cultural scope and helped navigate best public health practices to fill a gap that was happening for Indigenous community. And it was presented through our network and through channels of communication rather than from the university itself at the beginning. What I want to show you here is just a timeline of this information. What you see in the beginning of this graph in 2020 in January is the existing Indigenous health library at University of Toronto. And at that point in January 2020, there had been under 40 hits of that content. So 40 searches of Indigenous health. At the beginning of March, between March and May of the year, we jump up almost immediately to 2,000 access points. And that happens the day after we launched our COVID-19 resource guide. I show this because I think it highlights really vividly the demand that existed in Canada for Indigenous specific public health materials. And what we saw pretty, incredibly was how widely this resource became shared and disseminated. We have other metrics showing how it was used online, the networks of public health agencies that it went to almost immediately. But we have seen this sort of initial accessing point, and then as public health resources became more readily available to Indigenous communities, it does peter down quite a bit, although it does stay substantially higher than the pre-existing Indigenous health information index through University of Toronto. I guess what I want to show you today are some of the lessons that this resource guide on Indigenous public health communications and mental health promotion has taught us. Specifically, what you're going to see here is kind of a first round, what we might call a holistic analysis. It's a coding method described by Day in 1993 as an attempt to grasp basic themes or issues in a large set of data and absorbing them as a whole, kind of lumping them together in key themes. It's often described as the first stage of thematic analysis. Saldana also describes this method as appropriate when researchers are trying to understand as a preliminary step to grouping data into broader topics before a more detailed analysis. It involves reading through the body of text or images to establish a bigger picture rather than a line-by-line approach. We initially are presenting findings like this, although we're in the midst of a more rigorous review of analysis at a more sequential line-by-line approach. But just to provide a kind of in motion picture of what we're seeing in this archive, which again wasn't initially developed as a data repository, but given its uptake, we have applied this analysis to it to better understand what we were seeing at this juncture of time in Indigenous public health communications. It provided a really unique moment to look at some of our findings. So the first theme that we really see is that the need to contextualize Indigenous public health communications and mental health promotion within Indigenous peoples' history with pandemics. And really two pieces of that. One, to really acknowledge that one, pandemics are not new to Indigenous people, but actually we have a long history in Turtle Island and around the world, of course, in responding to novel pandemics. And that exposure is well narrated within our communities. The second component is that Indigenous peoples actually have a great deal of wisdom and history in adopting pandemic public health measures, resistances, and care practices. So I want to just highlight some of the ways in which we saw that in our work. This is an article that was in our resource guide, which tells the story of Nuu-chah-nulth people 5 generations ago, quarantined in a cave in a river valley in their own home territory to survive the smallpox pandemic of the time. What we see in this article and in interviews with communities on Vancouver Island and certainly elsewhere in Canada is that there are true examples of social distancing or physical distancing well narrated within the histories of Indigenous peoples, linking the contemporary COVID-19 public health measures of social distancing to this history has an important narrative function to help encourage more relevant adoption of this public health measure. We also see here these wonderful images, which are now everywhere. At the time when they first started popping up, they were on Instagram initially. But we see the use of linking public health traditions around physical distancing and social distancing and hand washing, really to cultural narratives and values of the protection of elders and knowledge keepers. We see this as a particularly wise example of really instilling the values of social and physical distancing, but through a lens that is more culturally situated. This third one, which I'll speak to briefly, is an example from the Mama Way Project, a social media campaign and an organization which promotes Métis identity. We see a linking of physical and social distancing with Indigenous language and the history of that language. Let's stay inside, the word that's highlighted in the metaphor of the day. I think this is a really powerful example of the significance of linking language and Indigenous language and the epistemologies and ontologies that it holds, the responsibilities and ethics that it denotes in communities to the behavioral changes that are needed early in the pandemic. The second theme we really saw emphasized was, let me just make sure I'm not missing anything important. There we go. The second thing we saw emphasized was the importance of a trauma-informed characterization of Indigenous health risk. There's a lot of interesting examples of this in the resource guide, but one part of it at least is really recognize the importance of trauma-informed approaches to public health measures, including mental health promotion, and attending to dimensions of both individual and communal risk. The second area that we really noted this in was in recognizing that mental health inequities for Indigenous communities are often socially structured, and these determinants are often highlighted and laid bare in the midst of this pandemic. These are two of the sort of key issues that are emerging from this repository of material. I'm going to show you that in just two ways. One is a report that was in the, one example is a report from ITK early in the pandemic, where we see a special call to Indigenous Services Canada and more broadly to Health Canada and the Public Health Agency of Canada for Inuit to be considered a high-risk group. Now that label, high risk, has very particular connotations that I think are important to sort of question and contextualize in relationship to the needs of communities, but also to think about the ways in which it denotes a certain negativity around communities. And going back to Dr. Tam's statement early in the pandemic, the sort of ways in which Indigenous people were framed, or the needs of Indigenous people were framed as high risk, is maybe factually or environmentally or ecologically true, in that the environments are promoting risk, but it can also run the risk, so to speak, of pathologizing specific groups of people. We also see examples in this archive from places like the Canadian Centre for Policy Alternatives in Manitoba, the connection of this risk to things like housing. And I think this study by Shirley Thompson, Marlene Bonnycastle, and Stuart Hill really emphasized the kind of crudeness of saying, point blank measures around physical distancing or social distancing in context of overcrowding and perpetual inaction on housing infrastructure in the Canadian context it can be a bit insulting to Indigenous people. The third theme that we see, and probably I think the most relevant to public health communications, is the importance of credibility and relevance of public health information. Really acknowledging that information, and in particular health information, is not one equally accessible, nor does one size fit all in terms of existing inequities. And then the second thing being reckoning with the rising tides of non-credible health information and addressing the broader ways that health and mental health related knowledge is irrelevant because they're often framed in ways that are culturally or contextually disengaged. And so the key factors really become ensuring that the information that's shared is credible and that the relevance of information is legible. So this is an image that probably, although our Prime Minister has had relatively more or less facial hair over the course of this pandemic, everybody can groan at that joke, but this has become sort of a commonplace feature of the Canadian public health approach, which was very early in the pandemic to begin putting influential political leaders on camera in front of the TV every day. And so many of you will remember that early in the pandemic, Justin Trudeau was basically on TV every day giving us updates, and that still happens, although the majority of Canadians no longer watch them. At the beginning of the pandemic, there was public health information, really important and critical public health information presented through mainstream media outlets by the Prime Minister and major public health officers that were not actually getting into the hands of people most directly affected, like Indigenous people. And so what we start seeing in this archive is much more diverse means by which people are getting this same information. Indigenous radio as an example, Indigenous podcasting as an example. About midway through the last year, public health authorities within provinces began putting Indigenous lead public health officers on camera and on major Indigenous networks like APTN. This, I think, is a good example of speaking to the credibility, both in terms of audience, so who's listening to what. Not every Indigenous person is going to be as engaged in mainstream public media as they might within more local, decentralized, and also Indigenous specific public media. And then also the relevant interlocutors. Is it better to have someone like Justin Trudeau or Dr. Tam, or to have an Indigenous public health specialist speaking to Indigenous people, or elders speaking about vaccinations? The credibility really matters. In terms of relevance, we see really important examples. This one from Anishinaabe-Aski Nation, representing dozens and 40 plus, almost 40 Indigenous communities across Northern Ontario, using language, Indigenous languages, and thinking through the variety of resources in this database, which adapt public health measures like hand washing and sanitation procedures in ways that reflect commitment to multilingualism, that show cultural norms and assumptions, and to recognize that these things shape effectiveness of communication. This is probably my favorite example from the archive, and I'll just throw it here briefly. I guess, the SKODEN principle or the SKODEN protocol is an example of where good acronyms and for hand washing really come into effect, and broader social distancing protocol, but really taking something that might otherwise not mean something to the majority of Canadians, but recognizing how something that memorable and that iconic could mean something very specific in the context of Indigenous communities, in particular young people. So I guess in summary of that section, the practices for credible and relevant health information that we see as being very central is really the use of relevant and reputable sources of information. And those need to be defined not by the government, but by communities, to make use of prominent mainstream and digital Indigenous media sources, and to encourage Indigenous community organizations to adopt communication standards and verification processes related to health and mental health information, and also to ensure that all health information is in a relevant language and is culturally appropriate. The fourth major theme that we see in this first round of analysis is that we do have issues of ongoing access and quality of mental health services. And so navigating the realities that pre-COVID-19, there were significant service needs for mental health and existing challenges to accessing services, and that telehealth and virtual care psychological services are severely limited both in availability and accessibility. And so, a lot of the solutions offered by the government, which we'll see in a minute, really presuppose access to things like internet, presuppose access to things like stable televideo communications or telehealth communications, which aren't really guaranteed. And then also pre-existing documented concerns about the quality of mental health services for Indigenous people are something that show up often in this archive of materials as well, and really speak to the need for greater and broader workforce education, training, and supervision, and the question of whether mainstream approaches to mental health service delivery are culturally valid and relevant for Indigenous people. A couple things from the archive that I think speak to this. This article highlights the lack of connectivity in First Nations communities. So while the government is pitching the Hope for Wellness line, a chat site that's never been evaluated for its actual clinical efficacy, this entire approach, which is the main approach for addressing mental health crisis by Indigenous Services Canada, really presupposes access to technology, which not every First Nations community, particularly in more northern and remote access communities, don't have. The fourth theme, and I guess the final theme I'll speak to today, is really what we see through this archive is the central importance of community-based cultural approaches to supporting well-being, and to really establish and nourish commitments and a practice of elevating existing and emerging community efforts to promote mental health and well-being by Indigenous peoples, and to finding ways to integrate these into therapeutic practices, both in everyday and in clinical ways, but particularly into therapeutic practices that have to do with the treatment of and prevention of COVID-19 transmission in communities. A couple of ways in which we see this here. We see a number that, this is just a list that come from the first splash page of our website. Messages from ceremonial elders, jingle dress dancing, children's books, Two-Spirit specific content, maternal content or maternal pedagogical content, really examples of where people's own culture is centered in the care and support of Indigenous people. WCH, CWP, Indigenous Health released this really wonderful model of thinking about Indigenous well-being in the midst of COVID-19, really based on existing prominent Indigenous health frameworks. We see here trauma-informed based programs to support youth mental health in the midst of the pandemic, integrating land-based approaches. This is, I won't show this video today, but it's one of many examples of healing dances that were transmitted early in the days of the pandemic, especially the jingle dress dance, which has a really important, rich cultural history in relationship to healing and traditional medicine. And then I think the last one I want to just highlight is more recent, really using social media to transmit images of Indigenous people, adopting public health recommendations like the use of PPE, like the use of vaccinations. So concluding thoughts, I guess I would say, again, this is very preliminary research, a kind of novel use of multimedia materials and research for me. But really the three things that I want to leave you with as highlights are the importance of contextually informed, culturally relevant, and transformative mental health practices in health communication. The second thing is to think about the importance of strengths-based practices, that is the use of culture to address various forms of inequities. If we're to address mental health, we have to ensure that public health communications is really anchored in effective communication approaches for Indigenous people. And then the third is the need for ongoing research and evaluation of practice-based knowledge for Indigenous public health. So thinking through what practices are needed for the years ahead. And I guess that's probably where I will stop for now, in mind that we have some time for questions and conversation. Thank you so much, and hope this has been useful and thought-provoking for you.
Thank you very much, Dr. Ansloos. That was really exciting to hear what you're doing right now. And I was particularly taken at the way that you collaborated with the Oise Library. I think that was amazing. And I'm going to read some of the questions, but I'm just going to ask you just to elaborate a little bit on how that partnership developed, because I think that a lot of those within institution collaborations don't happen often enough, and they are extremely powerful when they do.
Yeah, so I can speak to that briefly if you'd like. I guess the first thing is that we make in the Indigenous Education Network, where this project was sort of born, we have a regular meeting with our Indigenous outreach librarian to sort of think through the ways in which we can promote effective communication around issues that are important to Indigenous people. So that's like an ongoing iterative conversation that we're always involved in. But early in the pandemic, it just became so clear to me that there was a real gap in credible information and no systematic or organized way to generate a sort of secure base of information, there was a clear gap. And when I talk to librarians in general, I always sort of feel and find that they are information experts. They have a much different set of tools, a whole different understanding of ways of organizing and collating information. And in conversations with Desmond, it just became so clear that we needed people who were academics, we needed community members to participate, and we needed the expertise of librarians. And I think if there's academics and researchers on the call, what I would really want to say to you is that it's really important to consider your librarians as research colleagues, as people who are credible co-investigators and necessary partners in effective research with Indigenous communities. They have an area of expertise that we don't, and that really added to the work. I guess the other thing I would say is that it was very hectic and informal, and kind of in motion the whole duration of the pandemic and continues to be. And it's only recently that we've really sat down and thought through, okay, what did we do? And what can we learn from it?
Awesome. Well, that's good to know, because, you know, in the 15 years I've been at U of T, Desmond is still the only librarian I actually know. And he is terrific. So I hope he's here today. So another question really is, how can we overcome some of the challenges that have arisen with engaging with knowledge keepers and traditional healings virtually?
Yeah, so that's a really interesting question, and is something actually that's popping up in our second review of the line by line and image by image analysis, is that there's clearly an evolution over the course of the pandemic by which elders were engaging in community-based responses online. Early in the pandemic, a lot of the content that we see is very much about like the protection of elders, the safety of elders and knowledge keepers, and really ensuring that community, in particular, communities with greater health disparities, would adopt behavioral practices in the protection of knowledge keepers. Over the course of the pandemic, what we begin to see is actually a greater presence of knowledge keepers in digital spaces. And I think what's most interesting is that there is evidence, there is some indication that as the pandemic is emerging, Indigenous knowledge keepers and elders are developing protocol for integrating cultural teachings, integrating ceremony into digital environments. That's obviously not without hiccups, it's not without challenges or tensions, but we do see sort of a progression of knowledge keepers doing that online. One of the ways that it becomes really important is visually. As we see elders and knowledge keepers online, it's really important to give consideration to people who are working with them in those spaces wearing PPE, people who are working with them in those spaces wearing masks, people who are working with them in those spaces modeling social distancing 6 feet apart in those video spaces. So really thinking about the ways that the visual cues also suggest something about how to promote the health of elders in those spaces. I think the other thing that I'll just briefly mention, which is its own like talk, is to acknowledge the spiritual dimensions that I think elders talk about in digital spaces, and to think about the ways that things like the use of medicines, which was treated as misinformation at the beginning of the pandemic, how elders are actually talking about a type of spiritual healing in response to the pandemic, and to not misunderstand what sorts of information and teaching are coming through these digital spaces.
Thank you. Because that's a question that comes up with in a lot of different contexts around, you know, how do we deal with spiritual knowledge transmission in a digital setting? And I think that's evolving, as you say. So I have to put my glasses on to read the smaller print here. Please speculate as to how the term high risk and activated provincial children's services providers and created continued interruption of connection with family and community of origin during the pandemic.
Yeah, so that I guess I can speak to that from what we have learned generally and what we see in the archive of material itself. So generally speaking, risk is always a tactic that's used and employed by the federal government and its provincial counterparts to justify certain types of intervention within Indigenous community. And we can see that in every sector: healthcare, child and family services, social welfare, housing, the law, policing, you name it. So I think that argument is not really an argument, it's quite evidenced in history. And I think the evaluation of the specific impact of the ways that COVID-19 has been instrumentalized as a justification for child apprehension, or for on the basis of neglect or on the basis of maltreatment, is a really unknown outcome at this point, but I think it's an important question for years to come. I think what we see in the archive is a variable difference between the ways that Indigenous communities are talking about risk and the ways that federal and provincial health organizations are talking about risk. The key difference is that Indigenous organizations are often pointing towards existing health inequities, which are solvable products of racism and colonialism, and the ways that risk is described often, even by Canada's own chief medical officer, are often pointing at people. So one being the sort of ways in which risk is real in that it exists within structures versus the way that risk is instrumentalized to point to the sort of ticking time bomb nature of being an Indigenous person. I think both of them have very dramatic implications on how people and how ready people feel to adopt public health recommendations. I guess the one other caveat I would say is that oftentimes even Indigenous governance organizations sometimes use this more individualistic understanding of risk strategically to leverage increased resources. So it is a bit of a tricky and loaded idea.
Thank you very much, Dr. Ansloos. So I'm going to turn it over to Knowledge Keeper Clayton Shirt to close us, and then we'll just end the session. But before I do that, I want to thank you again, Dr. Ansloos, for making the time to share your research and your passions here with us. And I'd also like to thank all of the attendees who came out to listen and share ideas about this important work. So miigwech to all of you, and thank you also, Clay, for being here to keep us grounded in spirituality. And thank you, Blueberry, for being there. Can we see her before Clay closes? Oh, you're muted.
She's somewhere else now.
Gone. Okay, well, next time you'll have to bring her to the webinar. Okay, so Clay, any closing remarks and spiritual prayer closing?
No, just thank you, Jeffrey, for your good words. Oh, there she is. It's gorgeous.
She's huge.
So again, Jeffrey, thank you for your good words. And I'll just take a moment or two or three, people, and just sort of gather your thoughts. And I always try to remember, and just I take what I need and out of these good words and help us, serve us. And just always reminding myself that why we're here, to work for the people. So I say miigwech to all of you, and I ask you, of all of us who are in this virtual circle here right now, to offer our prayers to our brother Jeffrey, because he's doing all this good work, and the ones who work for the people, they make sacrifices from their own family. So I just like to say miigwech to Jeffrey and ask for blessings for his family and his loved ones and all of this. So I say miigwech to our Creator for this, and I say ask him to guide him physically, mentally, spiritually, and all the work he's doing for the people. So I say miigwech to the earth again, to the sun, to the sky, to the universe. And I ask for all the people who are in this virtual circle for blessings for all of us. Again, I just stand here as just a man. I ask for blessings for all of us, physically, mentally, spiritually, emotionally. We're all in this together. And may we always have this in our minds and our hearts. So again, I say miigwech to our Creator for this beautiful gift you have given us called life. All my relations. Miigwech.
Miigwech, Clay. Thank you and goodbye. And we'll see you all next time.